Good afternoon, everyone. So, welcome to the 84th session of e-NISCHIT. e-NISCHIT, as we all know, it stands for our national initiative to strengthen collaboration between HIV TB through e-learning. I welcome you all. And along with me, I would first like to introduce my panel members and our expert and case presenter today. So, here at NITRD, I have Dr. Anuradha on the left from Share India. I also have to support us in IT part and logistic part from Share India, we have Rakesh, and from ECO, we have Ankur. And our expert for today is Dr. Alok Yadav. It's indeed a big pleasure to invite him. He's the he's the chief medical officer and pediatrician of our institute and has vast number of years of experience in dealing with childhood, not only tuberculosis, the varied other diseases. So Dr. Alok, can you please say hello to everybody and to all our members, folks?
Hello everyone, I am myself Dr. Alok Yadav. I am Chief Medical Officer in NITRD. Currently, we are taking care of the resistant tuberculosis and the children who need surgical intervention in this institute. This is the referral center for all over the India and excellence center for in treating the tuberculosis cases by the TB Association, Ministry of Health and Family Welfare.
Thank you, sir. Thank you, sir, for giving us your precious time. I would also like to introduce our case expert for the case presenter for today, Dr. Anuradha Johri. She's a senior medical officer from MDR Center, BHU. Ma'am, can you please introduce yourself?
Good afternoon, everyone.
Good afternoon, ma'am. So childhood TB as adult TB or any TB HIV, it's a curse to it. We all know that TB and HIV, how they are, it's like a curse. TB makes HIV worse and HIV makes TB worse. So that's in the case of the children as well as we see in adults. But in children, there are additional problems also because it is very difficult to identify the TB at the right age, and then it's very difficult to handle their drug interactions. But and particularly if we talk about our HIV children, they even though because of that all the vertical transmission that we are trying to cut, there are less of HIV infected children we see, but they are still exposed in utero. So their immunity is impaired compared to children who are not exposed to HIV. So definitely with impaired immunity, they present with TB. It is a difficult case to handle. So right now, in this session, we'll be focusing on guidelines on how a TB management is done in children in pediatric. So today's session is going to broadly focus on the TB management, and we all know that drug-sensitive TB, and in this session we'll also be enlightened about the drug-resistant TB and how regimens are made, so that when we see a case like that, we have some knowledge, can identify some adverse reaction due to some drug or something, and we can give a better advice to our patients. So I hope our today's session is very fruitful. I'm very positive it is going to be very fruitful for all of us. Now we'll have the case presentation. Dr. Anuradha.
Good afternoon, everybody. I'm presenting a case of a 10-year-old male child weighing 19 kg, a resident of Mirzapur, who came to us on 7/7/17, and his ATT was started on the same day, and ART was initiated 5 days later. He was referred from a private facility. He presented with complaints of mild-grade fever off and on, decreased appetite, and weakness, all this lasting for 1 year. There was a past history of Duovir half-tablet intake, OD for 40 days, and Moxiflox and arsenic skid privately for 15 days. There was no history of pox in the family. Both parents are retropositive on ART since 8/7/18, and they are virally suppressed. On examination, the child was febrile. Vitals were within normal limits. Malnourished child whose weight was 19 kg against an expected weight of 37 kg and a height of 130 centimeter against an expected height of 139 centimeter. And he fell into the grade 4 of IAP grading for malnutrition. There was no pallor, icterus, cyanosis, edema, or lymphadenopathy. All systems were within normal limit. Per abdomen, we got liver 2 centimeter and spleen just palpable. With these constitutional symptoms and severe growth retardation, we went on to do some investigations, all of which were within normal limits, except an ultrasound which showed retroperitoneal lymph nodes with a size, lymph nodes of the size 12 to 16 millimeter. At this time, the X-ray chest was normal and CBNAT and AFB smear of the sputum were normal. With this, we made a presumptive diagnosis of abdominal COX and started ATT on a trial basis as the child's weight, according to the child's weight band. After 5 days, we started ART in the form of ZL, pediatric ZL and FAV. CD4 was low, so the ART was started as soon as possible. Adherence of the patient was always 100%, and the attendant was his mother, who was very compliant. At 3 months, the patient showed no improvement, and at 3 months of start of ATT, the patient showed little or no improvement with low-grade fever persisting and a decreased appetite. He was given a course of antibiotics, anti-malarials, fever persisted. Urine at that time was within normal limits. Dipstick for Kala-Azar was negative. LFT was within normal limits. X-ray chest was also normal. USG showed per abdomen lymph nodes persisting. The CD4 at this time was 88 and initially it was 31. A viral load was TND. Hence the possibility of TB iris was suspected and a short course of steroid was given for 15 days. At 9 months of start of ATT, the child came with shortness of breath for 15 days. And we suspected PCP because the child's PaO2 was 67, his CD4 was persistently below 100, and he had a high LDH. And the chest X-ray showed parahilar infiltrates. So he was hospitalized and managed on steroids and Bactrim DS. As PCP is a stage 4 condition, we suspected failure of ART. However, the viral load remained TND, that is target not detected. 3 months later, at 12 months of start of ATT, the patient presented in the OPD with 2 months history of fever, gradually distending abdomen, abdominal pain, and constipation. USG was repeated, which showed gross ascites with matted lymph nodes, which had increased in size to 2.5 centimeter into 2.5 centimeter, and there were mesenteric lymph nodes. USG guided FNAC was attempted but failed. Ascitic tap showed an exudative fluid, and CBNAT of the fluid was negative on 2 occasions. CD4 was 62 and viral load was TND at this time. The CT thorax was done, which showed bilateral opacity, ground glass opacity, and centrilobular nodules, multiple centrilobular nodules, and suggestive of showing a tree bud-like nodules, and which was suggestive of PTB, and there were also necrotic mediastinal lymph nodes. CT abdomen confirmed the finding of USG and therapeutic confirmed the finding of USG, and normal ecotexture of the liver was also established. The portal vein caliber was also normal. The lymph nodes were matted, large, and necrotic. We gave a therapeutic drainage of the fluid twice under albumin coverage. So basically, since we have given ATT for 1 year, and there was still progression of TB with involvement of the lung and worsening of the abdominal box. So on the basis of this, we had a clinical suspicion of MDR TB, and we requested for second-line ATT by MDR TB cell. A committee was constituted and it advocated MDR drugs. And MDR therapy was started on 9/8/18 to 9/2/20. The child became afebrile after 2 months of start of DRTB therapy and rapidly gained weight from 19 kg to 45 kg and height from 130 centimeter to 150 centimeter. So that is the end of the case. The issues which are posed for discussion are given the that the sensitivity of CBNAT in ascitic fluid is low, a high index of clinical suspicion should be kept for the diagnosis of MDRTB. And the other thing is that the diagnosis of DRTB in our algorithm is based on CBNAT detection of MTB. And it's not always possible because in children, it's a paucibacillary type of TB. So it's not always possible to detect the Mycobacterium tuberculosis. So what would be the things we should keep in mind for a high index of suspicion? Over to Dr. Alok.
Thank you, ma'am. I think it's an excellent case and to be discussed on a platform like this, and all of us are going to learn a lot from this case, and it has been very well managed. I would like to congratulate on that. You saw a malnourished child and you gave him presented TB, and when he was worsening in spite of a year-long treatment of TB, you had the clinical suspicion high and you started on MDRTB, which was life-saving for him. So this case has been managed well, but then it brings us back to the same question, which is a very burning question in childhood. Dr. Alok sir will elaborate on that identification of MDR-TB is still a big problem. Then there are other so many hurdles along the way. But first, most of the time we do just fail to identify because of this nature of TB in children that we don't have in culture, ready cultures, or they are not expectorating sputums, and we don't have enough samples to give a proven diagnosis. So clinical diagnosis is the mainstay. So that way, that is what we are going to learn in our latitude today, that TB in children, how do we approach that? So with that, I would like to invite Alok sir to please give his editing.
Thank you, Dr. Ananya. I am very thankful to NACO India and for inviting me for such a wonderful case of TB/HIV, DRTB and HIV. I am very thankful to Dr. Pasna ma'am, Dr. Ananya, my colleague, and Dr. Anuradha, who gave his persistent technical support and coordinate with all the members to make this case in a great direction. So before initiating, I want to share my PPTs. Can I please just... So case was very well managed by the ma'am, and at the end of the 1 year, when the child was not improved, they with the discussion of the DRTB committee, they started the DRTB management. So first of all, recently there are guidelines. WHO also revised the guidelines in 2021, and recently in 2021, Government of India also released the DRTB guidelines. So how to approach the case of the DRTB, that is a bit challenging issue, and how to work out and how to find out the DRTB cases. Right now, we come into the summary of the cases, which ma'am had already elaborate in their discussion. So in the crisp, I just go through the summary that which are the point which is favoring the tuberculosis. So the child has fever from last 1 year, child has decreased appetite, not gaining weight, the child is malnourished and the BMI is 11.24 kg per meter square. Radiologically finding are also suggestive of the tuberculosis. So these are the points which are the favor of the tuberculosis. Point which are against in the tuberculosis, there is no past recent family history of the anti-tuberculosis treatment, no contact history of the TB diseases, no history of cough for more than 2 weeks, no history of the abdominal pain, abdominal distension, no history of the intestinal obstruction, and no history of the lower GI bleeding, chronic diarrhea. So ATT started on the basis of the symptoms and only on the radiologically finding. Initially ATT was started on only on the basis of the symptoms. So what are the radiologically finding which you find in this case in the CT finding and chest X-ray finding. So CT finding, if you show the CT finding, there is mediastinal adenopathy. In the chest X-ray, you also find the mediastinal lymph node are enlarged. Here also you can find the mediastinal lymph nodes are enlarged. And if you see the window of CT scan, you saw that there is little lower zone opacity and treatment appearance in the CT scan. So in the chest CT, you find these radiological findings. And when the child has gross ascites, and at that time when the CT or abdomen was done, then that time the finding was increased peritoneal thickening, omental thickening, and necrotic and mediastinal lymph node, necrotic mesenteric lymph node are there, and thickening of the cecum and narrowing of the terminal area. So these are the findings in the CT abdomen. So let's come on the cases. At the end of the 3 months, system persists after course of the antibiotic and TB, ATT, no radiological improvement was found. So at the end of the 3 months, TB iris was suspected. Because the symptoms are not improving, the radiologically conditions are also worsening, and there is the new lymph node which was arrived at the 3 months. So TB iris was suspected. At the end of the 6 months, when child was readmitted in the BHU, then then there is suspect of the ART failure because child developed PCP, pneumocystic pneumonia. And at the end of 12 months, when the child comes back, then the child has fever, gross ascites, abdominal pain, and constipation. So these are the typical features. After which 12 months later, the child was presented in the OPD. So at that time, when UCG abdomen was done, there is conglomeratic mediastinal lymph node, which was size 2.5 into 2.5 centimeter, chest CT necrotic and mediastinal lymph node, CT abdomen increased peritoneal thickening, omental spread of matted and necrotic lymph node, and CB that was done on the ascitic fluid that was found negative. On the basis of the clinical finding, the DRTB committee recommended the DRTB treatment. So let's come on the abdominal TB. Just abdominal TB is an infection of any organ in the abdominal cavity, including the gut and the peritoneal. Abdominal TB can make us about 3% of all the TB cases. Abdominal TB most common site is peritoneal and intestine. In the peritoneal, there is the complaint of the abdominal distension, abdominal pain, and fever. In the intestine, the child, most commonly the child complained with the recurrent colicky abdominal pain, intestinal obstruction, chronic diarrhea or constipation, both can be found. Weight loss, palpable mass in the lower abdomen or lower GI bleeding. And after that, if you go to the diagnosis of the abdominal cause, abdominal TB, then the first we have to done the X-ray chest, HIV testing, ultrasound abdomen, CT or MR of the abdomen, and USC guided FNSE of the mesenteric retroperitoneal lymph node, which you can find enlarged lymph node, and ascitic fluid sampling. And these ascitic fluid sampling sent for the cytology, ADA, and for the gene expert. So most common, the child of abdominal TB can present for the abdominal pain, diarrhea, constipation. These are some important features for which the child has presented for the abdominal cause. So right now I come into the gene expert. As ma'am had told that in the pediatric guideline, the gene expert is the first test which we have to done in the pediatric cases. So what are the sensitivity of the gene expert in pulmonary and extrapulmonary sample? In the pulmonary sample, if the smear is positive, culture is positive, then the pool sensitivity is 98%, smear negative, culture positive, then pool sensitivity is 68%. In the lymph node aspiration sample, the pool sensitivity is 84.9%. Pleural fluid sample, the pool sensitivity is 43.7%. Peritoneal fluid, the sensitivity is 28.5%. CSF, the sensitivity is 79.5%. And gastric fluid, the sensitivity is 83.8%. So as you see that in the extrapulmonary tuberculosis, the sensitivity of lymph node samples, gastric aspirate sample, and the CSF sample, the sensitivity is good, above 80%. While the sensitivity of the peritoneal fluid is less, 28.5%. So you cannot find out the bacilli in this case, CBNet positive. So you cannot find out the TB positive in the gene expert in this case. So let's come the definition which was revised recently in 2021. What is the monoresistant tuberculosis? Monoresistant tuberculosis is any first line ATT, resistant to any first line ATT other than rifampicin. MDR cases is resistant to HNR. Rifampicin resistant cases are also managed by the DRTB. Polyresistant are the resistant of two first line drugs, but not both rifampicin and isoniazid. Pre-XTR resistant to HNR plus resistant to any fluoroquinolone. XTR, TBR resistant, MDR. Here rifampicin resistant TB also resistant to the fluoroquinolones. moxifloxacin, levofloxacin, and one or more additive group 8 bedaquiline or linezolid. So FGR definition have been revised now. There is some other definition: extensive or advanced TB diseases and severe extrapulmonary TB diseases. Extensive or advanced TB diseases presence of bilateral cavitary diseases or extensive bilateral parenchymal damage on the chest X-ray. So these are called extensive or advanced TB diseases. In the severe EPTB diseases, these comes under the TB meningitis, CNS TB, miliary TB, and in the children below 15 years of the age, extrapulmonary form of the disease other than lymphadenopathy, peripheral node or isolated mediastinal mass without compression. These also comes under the EPTB, are considered as the severe form of the EPTB. So comes on the diagnosis algorithm, how you can diagnose the pediatric tuberculosis case. If any child coming with a persistent fever of more than 2 weeks without a known cause, an intermittent cough for 2 weeks, weight loss 5% or not gaining weight for past 3 months despite adequate nutrition or failure of the nutritional rehabilitation in same with or without contact with patient with pulmonary TB last 2 years. So first investigation is chest X-ray. If you do the chest X-ray and chest X-ray suggestive of the tuberculosis, just like a mediastinal widening, just like a consolidation, just like a cavity you can find in the chest X-ray, just like a tracheal shifting, is there any? Then these are the chest X-ray which are suggestive of the tuberculosis. So in the chest X-ray, do the gastric aspirate and do the sputum for the NEAT approved lab. And when the NAT test comes positive, these patients are under microbiologically confirmed TB. So microbiologically confirmed TB may be rifampicin resistant or rifampicin sensitive. If rifampicin resistant not detected, then treat as a first line drugs. If rifampicin resistant detected, then reconfirm and follow the DRTB pathway. Chest X-ray, no specific shadow, give course of the appropriate antibiotic, and persistent shadow will present then to the NAT. If NAT was found negative, look at the test alternative site like enlarged peripheral node, consider repeat NAT from better quality specimen, alternative specimen like ball or lymph node aspiration, may seek review from higher center. If NAT comes positive after taking the repeat sample, then it was confirmed as the microbiologically confirmed cases. If NAT comes negative, no other alternative diagnosis, repeat as clinically diagnosed probable TB cases. So in the TB HIV, it is very important to find out the TB simultaneously in the HIV patient, HIV positive patient. So there is intensified case finding. If any child coming above the 12 months of the age living with HIV, then we have to do the screening, just like a poor weight gain, fever, recurrent cough, contact with the TB cases. If any of these was found, then assess for the TB and other diseases. If TB was found, treat as a TB. If non-TB was found, follow up and consider IPT. If other diagnosis was found, give treatment and consider for IPT. Assess for the contraindication. If there is any contraindication of IPT, yes, defer IPT. If no, then give IPT. Regular screening is necessary for all the cases who are living with HIV among the children. So what are the 4 symptom complex for TB screen among PLHIV? Among the children and adolescent, most of the symptoms are same, except in the children we consider as the contact with the TB cases, while in adult we consider as the night sweats. If any person coming with these symptoms, yes, investigate for the TB and other disease. If TB was found, treat for TB. If non-TB was found, follow up and consider for IPT. If any other diagnosis found, give appropriate treatment and consider for the IPT. Assess, is there any contraindication for the IPT, just like a chronic hepatitis or peripheral neuropathy, defer the IPT. If no, give IPT. IPT is to be given to all children more than 12 months. Screen for TB regularly at each visit of the health facility to increase the health worker. So any patient coming with the HIV infected child, if you suspect the TB, then if you suspect the pulmonary TB, do the NAT first plus chest X-ray. If NAT test was found positive, it comes under the microbiologically diagnosed case. NAT negative, X-ray suggestive of TB, then clinically diagnosed TB cases. NAT negative and X-ray negative for TB, then it comes under non-TB cases. Extrapulmonary TB, suspect NAT culture positive, sample from extrapulmonary site, cytology and histological examination and chest X-ray and other radiological examination. These suggestive of the TB, any one of more suggestive of the TB, then these comes under the extrapulmonary TB. So it is very important that when to suspect the drug-resistant TB in the children. So these are the 4 scenarios in which you can think about the DRTB among the children. If the child is not responding to the first line therapy, treatment after loss to follow-up, recurrent TB and others. Poor and non-response of the first line TB drugs is on ATT, poor response, no comorbidity, and still child is not responding to the anti-TB drugs. Treatment after loss to follow-up, if child is taking ATT for more than 1 month, loss to follow-up, microbiologically confirmed TB cases after loss to follow-up, then you can consider. For the DRTB, recurrent or relapse cases cured after ATT, now microbiologically confirmatory relapse case, then you can consider for DRTB cases. And contact of MDRTB patient or child living with HIV or with history of TB death in the household, then you can also consider as a preemptive DRTB cases. And when to suspect DRTB cases, after any child who is coming with you after taking the ATT of less than 1 month, then if the child is HIV co-infection, your child have AIDS, your contact history of the MDRTB, RIF resistance, history of family death, then you can consider as a DRTB. On ATT, history taking ATT for more than 1 month, previously treated TB cases, found positive in any follow-up during SPR, rapid diagnostic testing during treatment with first line death, failed treatment with the first line death despite adherence, pediatric TB non-responsive. These are the group of the children who are taking ATT for more than 1 month and coming to you OPD, you can think about the DRTB among these children. Next, when to suspect DRTB in children, a pediatric patient of TB with clinically non-response, with or without radiologically deterioration, despite adherence to ATT at the end of 4 weeks, with one of the following risk factors: exposure to a MDR, rifampicin-resistant pattern, or history of recent death in family due to TB, child who was earlier lost to follow, and whose microbiologically sample was negative or MTB, and there is no possible access of the specimen. In view of the prolonged duration and risk of second-line drug therapy, decision of such a situation should be made on recommendation of the DRTB committee. These children comes under the probable MDR cases. As in our case, you can see that the child is taking the ATT for more than 4 weeks, for more than 1 month, and child is also not responding to the treatment, and the sample was not also accessible in this case, and CBNAT was also found. So on the DRTB recommended, you can start the DRTB treatment. So when the sign and symptoms of the active TB diseases, and these are the additional factors: the child who has close contact with the DRTB, close contact with a person who died while on TB treatment, close contact with a person who failed TB treatment, non-responsive, or failed to the first line regimen, or previously treated with second line medications. And the resistance pattern cannot be determined, culture negative, sample collection site is not easily accessible, tuberculoma or abdominal TB. So in these cases, you can suspect the DRTB in the children. So how you approach the DRTB cases in the children? So any childhood TB patient come to you. So first you see the sensitivity pattern. Yes, sensitivity patterns. So that the child is drug resistant, then the treat as a drug resistant TB. If sensitivity pattern shows drug sensitive, then treat as a drug sensitive TB. And if you cannot find the sensitivity pattern, then the child contact is very important. Contact with the infectious TB patient. Yes, if source is drug resistant, this child comes under the probable DRTB cases. If source of the patient is not known, source is retreatment TB patients, or child is following first line treatment, then these comes under the presumptive DRTB. So drug sensitive treatment, drug resistant treatment of child or source specimen, if child specimen cannot be obtained. If sensitivity patterns show drug sensitive TB, treat as a drug sensitive TB. But if the child is not responding to the DRTB treatment, then send for the pediatrician as a probable DRTB cases. And if you found the drug resistant here, then treat as a drug resistant TB. What are the successful management of DRTB? Well, it is very important to make the correct diagnosis, correct categorization, correct treatment, and compliance is very important. to treat the DRTB cases. So at which condition child need to be hospitalized in the cases of the DRTB? Child under 5 years of the age with DRTB, extensive or severe pulmonary diseases, severe anemia, hemoglobin is 7 gram with or without heart failure, intolerance of any drug in the shorter, longer oral MDRTB regimen, child having severe malnutrition, BMI is less than 16 with bilateral pedal edema and middle upper arm circumference is less than 16. General condition is unstable vital sound, child is drowsy, stage of consciousness, shock, poor perfusion, saturation is less than 94%, child has hemoptysis. Underlying severe comorbid conditions like HIV, diabetes, other systemic disease like hepatitis, nephritis, underlying cardiac condition, any surgical intervention required in the chest for any emergency like pleural complication, and elective surgery for patient with localized lesion after bacteriologically conversion. And if there is any discretion of the treating physician based on the clinical scenario of the patient, you can also admit these patients into the ward. So let's comes under presumptive TB cases. The presumptive TB cases are the person living with HIV, EPTB, smear negative with X-ray suggestive of the TB and vulnerable group, contact of the DRTB cases, are notified TB cases and non-responder of the TB treatment. So first we do the NAT. If NAT we found the rifampicin resistant, then we have to do the first line LPA, second line LPA, and extended DST for the moxifloxacin, linezolid, clofazimine, pyrazinamide, bedaquiline, and the delaprate. The bedaquiline and the linezolid, these sensitivity are done under the WHO approved some center, just like our center, we have done the sensitivity pattern. If rifampicin resistant not determined, then we have to do the first line LPA. If rifampicin resistant determined, then do the second line LPA, DST for pyrazinamide. And if rifampicin resistant not determined, then give the sensitivity treatment. If rifampicin resistant determined, then do the second line LPA, drug sensitive treatment for pyrazinamide, DST for moxifloxacin, linezolid only if levofloxacin, moxifloxacin, or pyrazinamide resistant determined. In case of the rifampicin resistant detected. So if rifampicin resistant detected, then second sample, we have to send the second sample for first line LPA, second line LPA, liquid culture DST, extended DST for pyrazinamide, bedaquiline, clofazimine, moxifloxacin, linezolid, and delaprate. After pre-treatment evaluation, check the NITRD or with culture DST lab if LP results are available. If LP results are available and LP results shows that there is no additive resistant and H resistant determined with CATG or INH mutation, not both, and FQ resistant not determined, then shorter oral bedaquiline containing regimen you can give the. For starting the shorter oral bedaquiline containing regimen, we have to check the CATG and INH mutation. If both is not present, that then you can add the shorter regimen, and fluoroquinolone resistance also not found, then you can add the shorter oral bedaquiline regimen. If the LP results show as that both CATG and INH mutation and fluoroquinolone resistant determined, then all oral regimen should be started at this time. And additive resistance or intolerance, non-availability of drug in use or emergence of exclusion criteria or return to after follow-up or failure cases, then these children shifted to the longer oral MDR regimen, notified if needed as per the replacement table. And if the rifampicin resistant not determined, then do the first line LPA. First line LPA shows rifampicin resistant, isoniazid resistance, then isoniazid resistant treatment, S.M.O or poly-DRTB treatment is started. If H resistant determined, then stop drug sensitive TB. Drug sensitive TB regimen should not be given and stop drug sensitive TB regimen. Simultaneously reflex testing for second line LPA, liquid culture DST, moxifloxacin, linezolid, and clofazimine also sent. If in these drug sensitivity pattern, if found any additional resistance, intolerance, non-availability of drug in use, emergence of exclusion criteria, then modified S.M.O poly-DR regimen as per the replacement therapy should be started. If these patients are non-responsive or these patients who are S.M.O poly-DR TB regimen, these are not responding, then repeat NET should be done. And when the rifampicin resistant dot determine if you start the drug sensitive TB regimen and these patients are also not responding, then repeat NET should be done. So what are the things which you need to before starting the DRTB regimen? Pre-treatment evaluation. In the pre-treatment evaluation, the history and physical examination, height, weight, psychiatric evaluation is needed. In the laboratory evaluation, we do the sugar level, HIV testing, hemoglobin, TLC, DLC, platelet count, liver function test, TSH, urine examination, serum electrolytes for sodium, potassium, magnesium, calcium, urine pregnancy test, chest X-ray, and ECG. These are the investigations which we have to do in pre-treatment evaluation. So what are the principles for making the regimen a good regimen? So first, drugs we have to add those drugs not in used and DST shows sensitivity. Second preference is given to the drugs not in used DST, results are awaited. Third preference is given to the drugs used DST shows sensitive pattern. Fourth preference is given to the drugs used DST, results are not available, awaited. These drugs are not used, drug not used and DST show resistance, and drug used DST show resistance. These drugs are not used in which the DST shows resistance pattern. And the regimen prepared as per the sequence of the drug listing in group ABC of DRTB classification. So these are the preferences pattern and the drug we have select from ABC. So what are the principles for managing the MDR-TB children? Always treat in consultant with the expert preferred pediatrician available linked to DRTB. Include at least 4 to 5 effective drugs for group A and B to which the mycobacterium tuberculosis is tend to know likely to be susceptible. Do not add a single drug to the following regime to avoid amplification of the resistant. Strictly monitor of treatment by clinical examination radiologically and culture response of the underlying by pediatrician expert available linked to DRTB. Children age 5 year to 18 year of age and weight 15 kg are eligible for both shorter and longer regimen. Children below 5 year are not excluding from the shorter but instead give shorter course injectable regimen as the evidence of use of bedaquiline till the evidence of the use of bedaquiline is available. So the drug classification comes from the drug classification. The DRTB drugs are classified into the 3 group A, group B and group C. Medicine in group A is levofloxacin or moxifloxacin. Bedaquiline, linezolid. In group B is clofazimine, cycloserine, terazidone. And in group C, the drugs are ethambutol, delaminid, pyrazinamide, imipenem, cilastatin or meropenem, amikacin, ethionamide or prothionamide, and paraminosalicylate. So delaminid is a new drugs, but still it comes under the group C regimen. So this is a very important slide. That which regimen and how much duration of the regimen is given to the children. So children who are DRTB diagnosis there as a MDR cases. So pulmonary cases except extensive disease, non-severe form of the APTB. Non-severe form of the APTB you can go for shorter oral bedaquiline containing MDR rifampicin resistant TB regimen. The regimen is 4 to 6 months of the bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethionamide, ethambutol, high dose INH, and 5 months of the levofloxacin, clofazimine, pyrazinamide, and ethambutol. The duration of the IP is 4 months. At the end of the 4 months, if the smear found negative, then you can continue the bedaquiline up to the 6 months. And the drugs of high dose isoniazid and ethiomide should be stopped. But at the end of the 4 months, if you find the smear positive, then these regimens should be extended up to the 6 months, not more than 6 months. And at the end of the 4 months, you had also sent for the liquid culture sensitivity pattern for first line LPA, second line LPA, and extended DST. And whenever the result of these are available, then you can switch this shorter regimen to the all oral regimen as per the drug sensitivity pattern. Children below 5 years of the age, as the result of the bedaquiline is not much available in India, so the regimen of bedaquiline is we are given in amikacin and kanamycin in place of the bedaquiline. 4 to 6 months of the moxifloxacin, amikacin, ethionamide, clofazimine, pyrazinamide, high dose INH, ethambutol, and 5 months of the moxifloxacin, clofazimine, JD. In case of the disseminated extensive pulmonary severe EPTB, pre-XTR, all oral regimen are recommended. So these regimen is of 18 to 20 months of the levofloxacin, bedaquiline for 6 months or longer, linezolid, clofazimine, and cycloserine. So in these regimen, the linezolid is given for the 6 months, and after the 6 months, if the smear was found negative, then the dose of the linezolid should we do the half dose of the linezolid. And if we didn't found the smear was found positive at the end of the 6 months, then the linezolid will be extended up to the 8 months in this regimen. And in the INH monopoly resistant, then the regimen is 6 months of the levofloxacin REZ. So comes on this important table, how to replace the drugs. So as I already told, there are the 3 group A, B, C. In the group, if there is no need to the replacement of the drug, in group A 3 drugs, group B 2 drugs, and group C only we can take the 5 drugs. 5 drugs regimen is sufficient. So if we did not need any drugs to be replaced, then the regimen is 6 to 8 months of the levofloxacin, bedaquiline, linezolid, clofazimine, cycloserine, and 12 months of the levofloxacin, linezolid, clofazimine. If one drug need to be replaced from the group A, then the group A drug is 2, group B drug is 2, and group C drug is 3. If fluoroquinolone is need to be replaced, then we have to add the delamanid from the group C drug. And in place of the if bedaquiline need to be replaced, then the regimen is levofloxacin, linezolid, clofazimine, levofloxacin and linezolid from group A, clofazimine from group B, and delamanid from group C, and 12 months of levofloxacin, clofazimine, and levofloxacin, linezolid, and clofazimine. And if no linezolid is given, then the regimen is 6 to 8 months of the levofloxacin, bedaquiline, clofazimine of group B, and delamanid of group C, and 12 months of the levofloxacin, clofazimine. If the drug need to be replaced one group B drug, then the group A drug is 3, group B drug is 1, and group C drug is 1. If no clofazimine is given, then 6 to 8 months of the all drugs of group A is given, that is levofloxacin, bedaquiline, linezolid, and group B is cycloserine, delamanid, and 12 months of the linezolid, levofloxacin, and cycloserine. If cycloserine need to be replaced, then the drug regimen is 6 to 8 months of the levofloxacin, PDQ, linezolid, clofazimine, delamanid of group C and group B, and these are the group A drugs, and 12 months of the levofloxacin, linezolid, and clofazimine. One group A, group B, then 2 drugs should be added in group B, and 1 drug group A, and 2 drug in group C. The important thing is when you are adding on the group C, then the sequence is delamanid, amikacin, pyrazinamide, ethonamide, PAS, and ethambutol. These are the sequence whenever you need to replace the group C drugs. So these are the follow-up table. And the follow-up table in the shorter DRTB regimen, we have to do the monthly weight at IP and quarter in CP, smear monthly, 3 months onward till IP, and culture monthly from 3rd month onward, and quarterly in IP in the both scenarios. The important thing is that in the shorter regimen, if you find the culture positive at the end of the 4 months, then DST for first line, second line LPA. If culture found 3rd month or later positive, smear positive at the end of 1 month. So simultaneously, drug sensitivity pattern is also sent at that time. Chest X-ray, TST, and liver function test at the end of IP, CBC as and when needed, ECG at 2 weeks, and monthly in every 6 weeks. In all oral regimen, weight done at the end of IP and CP. The things are same, but here the drug sensitivity pattern at the end of the 6 months. If you find the smear positive, then drug sensitivity pattern is done at the end of the 6 months. You have to send liver function test every 3 months, TST every 6 months, ECG at 2 weeks, and monthly for 6 months. Now comes on the H-mono poly-DRTB regimen. So the H-mono and poly-DRTB regimen, the regimen is 6 months of the levofloxacin REZ. Clinical weight monthly till end of the treatment. Smear microscopy for 3 months onward till the end of the treatment. Culture at the end of 3 months and end of the treatment. DST, second line LPA, NAT, liquid culture DST. If smear culture found positive at the end of 3 months, extended of the treatment from 6 months to 9 months. So at the end of the 3 months, if the smear was found positive, then this treatment regimen will be extended to the 6 months. If the smear is positive at 4 months, at month 4, treatment will be extended from 6 months to 9 months directly. If the follow-up smear remains positive at the end of 5 months, declare the patient as treatment failure. Follow-up culture would be done at 3, 6, and 9 months if applicable. So this is the replacement table which need to be if any drug is not found sensitive, then these are the drug how you will replace that drug. If levofloxacin cannot be used, then levofloxacin will be replaced by the moxifloxacin. If second line LPA patterns so suggestive, LPA patterns so suggestive, do liquid culture DST for detection of the resistance of the moxifloxacin, pyrazinamide, linezolid, and clofazimine. If moxifloxacin and pyrazinamide cannot be used, then replace with linezolid. If linezolid also cannot be given, replace with clofazimine and cycloserine. If both moxifloxacin and linezolid cannot be used, then add 2 drugs. First, then add 2 drugs of the 3, linezolid, clofazimine, and cycloserine in the preferential order based on the resistance and availability. If rifampicin resistant, then switch to appropriate shorter or longer regimen. In the first 3 situations, treatment is extended for the 9 months. Treatment duration of H-mono poly-DR regimen can be longer in extensive pulmonary TB diseases up to 9 months. The use of new drug is recommended in the treatment of H-mono poly-DR due to lack of the evidence. So management of the HIV TB co-infection in infant and the children. This is very important. So HIV infected infant, children and adolescents co-infected with any form of the TB. So first start ART regarding of the CD4 count. Start ART first, initiate ART as soon as the TB treatment is tolerable between 2 weeks to 2 months. After starting the ART, after starting the ATT first, then after 2 weeks to 2 months, ART should be started. In HIV TB co-infection, the patient which have CD4 count less than 50 or child age is greater than 5 years of age need to start ATT first and ART within 2 weeks with strict clinical monitoring. Efavirenz is the preferred drug whenever child is being treated with rifampicin containing drug regimen for TB co-infection. However, in children less than 3 years and the children weight less than 10 kg, efavirenz is not recommended. Super booster loperamide and ritonavir must be given. BDQ should be used with caution in person living with HIV treated with antiretroviral therapy due to drug-drug interaction of bedaquiline and efavirenz, causing due to prolongation of the QTC interval. So the final we come into the preventive therapy. So the tuberculosis preventive therapy is also right now in the recent guidelines has also come for the tuberculosis preventive therapy for drug sensitive and drug resistant TB. For drug sensitive TB, we are giving the 6 months of isoniazid. Now there is another option of 3 months of HP, isoniazid and rifampicin in those children who are more than 2 years of the age. And in case of the drug resistance cases, if the child was found fluoroquinolone resistance, then you can give the levofloxacin for the 6 months. And if source is isoniazid or monopoly resistant, then 4 months of the rifampicin is given. So TPT therapy, all household contact of pulmonary TB cases, child over 1 year of age living with TBHIV, child living with HIV, irrespective of the TB. So all the children ask for the TB symptoms. If there is TB symptom, investigate of the TB. If you found the TB in any investigation, then treat for the TB. If no TB found, then if age is under 5 years, initiated TB preventive therapy without going for the investigation. If the age was found 5 years to 18 years, then it's better to test and treat. Test and treat ideally TPT if LTBA test found positive. But do not withhold TPT if testing not possible. If any center is not providing the testing, IGRA or Montux, then you have to give in these children also. Asymptomatic infant less than 1 year with HIV are only treated if household contact of the TB was found positive. Adjuvant pyridoxine, recommended group for pyridoxine prophylaxis when on isoniazid based regimen, malnutrition, HIV, renal failure, diabetes, pregnancy or breastfeeding or chronic alcoholic dependent. These are the groups which need adjuvant pyridoxine. So pyridoxine supplementation. As we all know that INH interfere competitively with pyridoxine metabolism by inhibiting the formation of the active form of the vitamin. So this may cause the peripheral neuropathy. Earlier supplementation was recommended for only the higher risk group HIV, malnutrition, diabetes, mellitus, renal failure and MDR TB. Right now, as per the recent guideline of tuberculosis preventive therapy, the prophylactic dose of the isoniazid for the pyridoxine is 10 milligram per kg in children, 20 milligram per kg in adult, and 15 milligram per kg in adult living with HIV. And therapeutic dose is 100 to 200 milligram per day for those who develop the peripheral neuropathy or sign of the peripheral neuropathy. So come to the case basically finally. So in the case, as you see, is that the child has history of the ATT for more than 4 weeks. Microbiological test for MTB was found negative. Child has bilateral parenchymal involvement. Child was HIV positive. Sample for EPTV but not easily accessible. And the radiologically also child was deteriorated. So my final diagnosis in this case is probable DRTB with disseminated TB and extensive advanced TB disease in the person living with HIV. So the recommended regimen from my side is all-rounder regimen for MDR, XDR regimen, 8 to 20 months of the levofloxacin, bedaquiline, linezolid, clofazimine, and cyclosamine. So this is the long presentation, I think. Finally, thank you. Slides comes. Thank you very much.
Thank you so much, sir. You have covered brilliantly on all the salient features of drug-resistant TB and TB in children, right from diagnosis to treatment to even TPT. So it was very exhaustive and because there were so many points to be covered. As a side note to that, I will be sharing this PPT with our spokes, all the spokes, so that they can go back to it. And even take a printout from the, I would advise you should take a printout of this and they should paste it in the area where they are dealing with the patient, because it's very difficult to mug up the doses or even remember what to do next. So it's okay to have the directions pasted on your front wall, because it's important you go in the right direction. You don't have to mug up. The now knowledge is not just, this can be just, all this can be just referred to whenever it needs to be referred. You just need to know what the right referring point is. So that's what we also intend to do. And thank you, sir. It was brilliant. And we have put the post-test poll. So, any question on any slide if somebody was not able to understand, but even though we are running out of time. So one thing I would like to ask you, sir, like when you see these drug-resistant TB patients, how do you counsel? And the parents must be having a lot of queries on their long-term growth. So such queries, such things, how do you handle? I mean, treatment parts is okay, but there's a psychological aspect to it.
Psychologically, thank you, Ananya.
Yes,
First of all, I try my best to put all the efforts to make these slides so that maximum message can be given.
Yes,
to
it was
audience.
brilliant. Thank you, sir. I'm going to put in my ART center your slides. Thank you, sir.
Thank you, Ananya. Thank you. So in your question, right now in the DRTB, before starting the DRTB regimen, it is very important to counsel the parents also, as you need that the age of the child is less. So you cannot counsel the child directly what are the impact of the DRTB and how much long the treatment is going on. So we have to counsel the parents. So we have counseled the mother and father both separately and in combination. Separately, we have to counsel the mother, as the mother is close contact to the children and she also take care of the kids. So we have to counsel first the mother, and my main counseling part is of the danger signs. What are the danger signs, and after starting the treatment, what are the complications she can face during the treatment. So if there is any complication, if there is any danger sign, then she can come back to our OPD or indoor. So that right time, the right treatment can be found out. Counseling is very important, as you all know these treatments, these drugs are giving of more than 18 to 20 months. So repeated counseling is very important. So most of the time I ask the attendant to come after 15 days. Initially I ask the parents to come to 15 months at the time of initiation of the treatment, and later I rang the parents and called these parents after 1 month or 2 months later on. So repeated counseling is very important in these cases basically. So you have to ask the parented and counseling repeatedly, and also tell the danger signs when he have to come to you in your indoor, in your emergency services. So right time, right treatment can be given in these type of the children.
So yes, I fully agree with you. And I would like to ask Dr. Anuradha, were your queries clear, or is there any final word you want to say? Please unmute yourself, Dr. Anuradha.
Yeah, I said I thought it's very clear now. Yeah.
Thank you, ma'am.
It was a good presentation.
Thank you so much. So now I'll ask Dr. Anuradha to tell us the post-test statistic, discuss the answers, and feedback poll is on.
All the participants, the feedback poll is on your screen, and I'll just tell you the answers to the pre and post test. First of all, I would like to tell you that the learnings from the session have been wonderful because we saw the response to the post test. They have definitely improved. So the questions are on your screen as well. The first question was, which of these drugs come under the group C of DRTB management? The choices were delaminate, bedaquiline, linezolid, and cycloserine. The correct answer is A, that is delaminate. The second question was, which DRTB drug should be used with caution in CLHIVs on ARVs? That is efavirenz due to drug-drug interaction and lopinavir, ritonavir due to prolonged QT interval. There were 4 options again to this. That is P-amino salicylic acid, bedaquiline, cycloserine, and linezolid. The correct answer is bedaquiline. That is B. Many of you, I think most of you have answered correctly in the post test. All appreciation goes to our case presenter for presenting the wonderful case, and of course our faculty for taking it up so nicely so that the participants could answer it correctly in the post test. Thank you so much, both of you. Thanks a lot. And feedback is there on the screen. It will be great if you can just give us your feedback. It will help us to improve in the next upcoming sessions. And the next upcoming session is on 24th of March. So kindly attend. The other states would be attending it. I would request if any of you want to attend the session again, you can do it on 24th. It will be majorly in Hindi, this session for the other states. So thank you so much for joining. Over to Dr. Nanya.
Yeah, thank you. Now I would like to just thank the case presenter and our expert for today. Thank you, ma'am. Thank you, sir. So in the interest of time, we have to close the session now. Thank you. Thank you very much.
Thank you.
This session so informative and successful. Thank you.
Thank you. Thank you.